next presenter really doesn't need a introduction, but I'm going to try to do him some justice. Dr. John Volpi is a Phi Beta Kappa graduate of the University of Texas who received his MD from Baylor College of Medicine, where he also served as chief resident in neurology. His clinical practice focuses on stroke and the critical care of patients with vascular neurological diseases. His current academic interests include the study of cerebral hemodynamics and artificial intelligence as a tool for stroke diagnosis. He is a recognized national and international expert in cryptogenic stroke diagnosis and management with over 100 peer-reviewed publications in journals and textbooks. He serves as a reviewer for the journal Stroke, the Green Journal Neurology, and has been an invited reviewer for NIH grants. Dr. Volpi is the director of the Eddie Skurlock Stroke Center at Houston Methodist Hospital and is the Elkins Family Distinguished Centennial Clinical Academic Scholar in Neurology. DJ.
Thank you, Nate. It's a real pleasure to be here, and after hearing Gavin tell us about therapeutics and all the things that we can do to treat and reverse stroke, it's important to take a step back and say that as a neurologist, it's our job to get the right patients to Dr. Britz and to get them at the right time and not delay in allowing them to have those opportunities. And that's really the focus of my talk today, and that's diagnosis. There are real opportunities here with artificial intelligence, but there's also challenges. And in our current research, it's about a team. And what I bring to that team is the way I think of stroke cases, and I'll talk about that, and what my colleagues, Dr. Wong, Kelvin Wong, and Dr. Stephen Wong, bring is a lot of expertise in artificial intelligence and how machine learning can help us in medicine. So if we were to say, what is artificial intelligence, I think of this picture as a good way of summarizing what we're doing. We're pulling threads together. And with the machine is taking data and different streams of data, pulling those different streams of data together, and then answering a question. So at the end, the machine will be given a validation to that question and a gold standard, and we have to tell the machine whether it was right or wrong using that gold standard. So just by way of example, you could take data like this. You could take pictures and say to the machine, are we looking at a chihuahua or are we looking at a blueberry muffin? And in this case, the stream of data is visual information. It's looking at an image, and it's trying to determine the combination of purple and yellow that makes a chihuahua versus the one that makes a blueberry muffin. And so the question at the end is chihuahua or blueberry muffin, and the gold standard is a human knowing which is which and telling the machine if it's right or wrong. But that's not the kind of questions we're asking. We're asking, is this patient having a stroke? And when we ask that question, we have to decide for ourselves, what is the gold standard for determining a stroke? Now, if you work in the front lines of stroke, you know this poster. You've seen it in your emergency room. You've seen it from American Heart Association, the FAST poster. And it really focuses on the clinical presentation. That's what you see in that patient when they're coming into the emergency room, the face, the arm, the speech. But if you see that patient through their clinical course and you're trying to diagnose them maybe 24 hours later on rounds, you're looking at an image. And that's what we're seeing on the other side here is the diffusion-weighted infarct that defines a stroke objectively. So we have symptoms or we have imaging, which is the gold standard for diagnosing a stroke. Well, the clinical data is readily available. It tells us the tempo, the acuity of the disease. You can take into account the patient's risk factors. You know your anatomy and you can localize. And you can also consider other alternatives. If the patient has a history of migraine or seizures, you may weigh that heavily in your determination. On the other hand, there's the test data. Our first test is a non-contrast CT. We often do a CT angio and perfusion now. And of course, the MRI. So which do we use? Do we use the subjective information as our gold standard, or do we use the objective as our gold standard? In some ways, there are pitfalls of subjective data. Can you even get a history? Does the patient have an ability to speak and tell you? And if they can tell you, are they reliable? Is this patient having a right-sided stroke where they may have neglect Or do they simply have a brain injury that's interfering with their insight? Then some things are just unknowable. We all use the term last known well because we accept that the actual onset of stroke is often unknowable. So we use that term, and that's just something we may never be able to discern from a case. And then there's the mimics, the patient who looks just like they're having a stroke, but they're not. Or even more worrisome, what we sometimes call chameleons, the patient who doesn't look like they're having a stroke, but they are having a stroke. So those can be very frustrating cases when dealing with subjective data. So a few years ago, the consensus of experts weighed in on this as an updated definition of stroke for the 21st century. And their primary means of diagnosis is pathological, imaging, or other objective evidence. And specifically, they cited the sensitivity and specificity of DWI as being greater than 95%. They did recognize the importance of subjective data, such as symptoms lasting 24 hours without other etiologies. But clearly, the prime diagnosis comes from an imaging-based modality. So we take that to heart, and we use that in our research as the gold standard when we ask whether a patient had a stroke. But there are issues with using a modality such as a diffusion-weighted MRI. Well, not every patient can get an MRI. Some patients have either stimulators or devices that prohibit it. And almost no patient can get an MRI as the first test. So regardless of how fast your MRI, regardless of how good your protocol is, there's a delay there. And while the diffusion-weighted image is highly sensitive and specific in general, there are some emergent care factors. The patient may move. They may have to transfer to and from the emergency department. They may not be stable for that transfer. And then when we look at the hyperacute patient, that patient presenting maybe within the first minutes after a stroke, that DWI may not even show much. And of course, bleed is important. It's important to rule out bleed, and there's less sensitivity for bleeds on MRI. So how do we blend this in our current practice? Well, for the most part, we were relying more and more on the CT technologies of CT angio and CT or MR perfusion. So first, for CT angio, it's highly effective for finding a large vessel occlusion, but limited to large vessel occlusion. A CT angio won't be positive without a clot that is obstructing flow. The CT-MR perfusion is itself an AI technology, so in many ways that's a success story of AI, and we should be happy that it's made it into the prime time. But it's limited at certain centers. Many centers don't have this technology, and its sensitivity is about 82%. And that 82% is in studies of patients with more severe symptoms. In other words, the studies of large vessel occlusion that use CT perfusion were patients who typically had higher NIH stroke scales. So in many ways, it's a success story, but it's a success story for moderate to severe strokes. So if we look at what our current imaging reveals, it reveals LVO detection, penumbra size, and it may help with wake-up strokes for TPA, and it may help us extend the TPA protocol beyond 4.5 hours. So that's where we're at with the CT imaging. But those patients are typically presenting with the NIH stroke scale higher than 4, and those cases really telling whether a patient's a stroke or not a stroke is pretty straightforward. In fact, it's the subjective judgment of the treating team, the ER team that already thought the patient was having a stroke, that led them to order the CTA and CTP. So as a diagnostic challenge, the challenge is not the severe strokes or even the moderate strokes, it's the subtle strokes. So how, as a technology, can we capture the subjective judgment of the stroke expert and the ER team that leads to that testing that will reveal an imaging-based stroke? Maybe we should take one step back and say, does it even matter if we miss the minor strokes? Does it matter if we have these misses? I think it does, because those patients are properly treated better with maybe dual antiplatelet, the point protocol. In some cases, even TPA may be appropriate if they're potentially disabling symptoms, even though they're subtle. And then really there's an evaluation that should take place with any patient who has a stroke. We should make sure the patient doesn't have a carotid artery that can be revascularized, or that they should have a heart monitor to tell us whether or not they may be having an occult arrhythmia. So really there's a high price to pay for a missed stroke. In some ways the most expensive thing in medicine is a misdiagnosis for those reasons. So we come back to this subjective versus objective issue. How do we integrate it? We need this subjective data because it's our pre-test suspicion. If you don't have a pre-test suspicion based on your experience, your expertise, and your attention to detail, then all you have is a non-contrast CT, which is the test that almost every patient gets. But that non-contrast CT is then negative, and you don't know whether or not the patient had a stroke because you didn't look. So we need to back up our testing to this moment, the very first moment when the patient comes into the emergency room and is in triage. That is a brief intake in a busy environment. So what we need there is this AI-based solution that can capture the subjective data and aid triage. So this is where the data streams will come together to ask whether or not the patient is having a stroke. So what are some sources of data that you can get in a triage environment? You can get the chief complaint. There's very straightforward demographic information. How old is the patient? There's vital signs such as blood pressure. And then you can video record a patient moving their face and answering a question. Simple question we all ask, the cookie jar thief, takes about 30 seconds. And during that 30 seconds, not only can you capture the face, but also the speech. So this is our model that we developed. And our model in this study was based on facial recognition. So to tell a little bit about our study, this was a collaboration with my colleagues here at Houston Methodist, Drs. Kelvin Wong and Dr. Stephen Wong, and our collaborators, Dr. James Wang at Penn State. It was a pilot study of 94 patients, and it used facial recognition alone. In other words, the machine got one data stream, the face video, about 30 seconds. But the ER doctor gets all the data streams, the patient, their family, the scans, the labs, the vitals, the chart. They get all that information. And at the end, the ER doctor is asked, is the patient having a stroke? We then compare the ER doctor's assessment, our machine assessment, with the ultimate DWI diagnosis. And that serves as the gold standard. And here's what we found. The ER doctor was 71% sensitive with an accuracy of 73%. Our model was 93% sensitive with 79% accuracy. So just a reminder, what does that difference in sensitivity mean? If you're having a lower sensitivity, you're missing opportunities. So by improving sensitivity, we mean we're having less missed opportunities to treat. So that's an important advancement. And some factors we know about missed opportunity is they're more common in younger patients, they're more common in women, and they're more common in patients with a history of mental illness. So these vulnerable populations are the ones that hopefully we're improving detection. But we don't want it to be like, everybody gets an MRI. We don't want it to be one of those situations where we're overusing resources. So we have to ask, are we being accurate as well? And we not only match the accuracy of the ER doctor, but actually improved, so we were not overusing resources with this model. So in conclusion, the new gold standard is not a human machine fighting each other. It's not arm wrestling. It's not machines replacing humans. But it's raising the level of the provider to match and really at times outperform experts. So it's this collaborative work between human and machines that we look forward to. So what is the AI toolbox? It may be facial recognition, motion capture, speech recognition, coming down to answering a question like, is this patient having a stroke? But really it's the new gold standard, is that AI is one of our tools as providers. The ER doctor then can even reach out to a virtual consult as another tool, and then they can add in their CTA, CTP, rapid scan as their third tool. And all of that coming together really means world-class stroke care everywhere. So with that, I'll conclude, and thank you all.